Peter and I are doing a double act. Those of you who have worked with us know that Peter and I often do a double act. He says it, I say it's so that we have a synergy and a support, and he says it's so I can interrupt him. But I'm not sure if that's the case. So today you will be the judge of that. Basically we've heard quite a lot so far about health equity. And I have a very short story to tell before I hand over to Pete to present some of the data from our new second Health Equity Status report. In 2018, the then Regional Director for Europe, Susanna Jacob, called me on the 4th of December, I remember. I was in Albania working. And she said, Chris, what are you doing on the 2nd of January next year? And I said, oh, I don't know. She said, great, you're going to come to Copenhagen, and I want you to do a review of how well Europe is doing around reducing inequalities. I would like you to do that and present it to me in 2 months' time. Well, I did go to Copenhagen. I did do the review, but she got it a year later. So, time frames, I live in Italy now, so time frames are slightly different. They are in Copenhagen. And basically, what we're going to tell you about is that journey. We started from a point of view of saying, why are we not making the progress? There's a lot of talk about it. So we spent 12 months talking to politicians, talking to communities, to professionals, talking to journalists, to understand what was the problem. And here we got at the top. When you talk about inequity, it's very generic, but we said, okay, you want to know about inequalities in well-being because that's where we can see if people are beginning to fall behind. What can we do around inequalities for people who are already unwell? And what do we do about the longer-term life expectancy? So we want equity to look at those things. And we found that these were the main barriers. A lot of the people we talked to said, it's just not possible. It's not possible. We should expect inequities in our society. And I'm reminded of something that Odd, my colleague, said this morning around this issue about buying back. There was a view at that time, and there still is, let's be honest, that some people will win and some people will lose. Well, what our data is telling us is who was winning and losing 20 years ago wasn't acceptable when it was 5% of the population. But when it's 15% of the population, or it's 20% of the population, that's not acceptable and it's stupid. What to prioritize? Okay, we're on board with you. What do? You give us all of these amazing things and do 100 things, but what is the thing that's going to level up the fastest? When we spoke to politicians, they said, yeah, we can't really get results in normal political cycles. And actually, a piece of work that we did with the previous report and we're bringing to this report was showing that actually with affordable investments in a basket of policies you're probably already implementing but not with an equity focus, in a country of 60 million, you can improve the lives of 150,000 people in 4 years of those policies being introduced, and we can prove it. We were also told, yeah, but there's not really a lot of support from business or from the public for these kind of policies. We actually showed that 84% of Europeans believe that inequalities should be at the top of their government's agenda. And then, how do we sustain those results over time? So, the Health Equity Status report was developed to respond to those barriers, to prove that wrong, to disable political and technical roadblocks, to shift the focus from talking about problems to talking about solutions. We've introduced, since then, a new initiative on Pathfinder countries. We know that countries who are taking this road want to connect with other countries to share learning, and I think that's what the Collaborating Centre will do, and my colleague Dorota will be talking about this on the panel this afternoon. And, as we said before, the data and the evidence is important. So we have data analysis and AI tools. Pete's going to shout at me in a minute. We are launching this report on the 7th of September, charting progress, saying what's driving equity and inequity, because if we don't also capture what's working, we can't accelerate those things. Signpost the concrete solutions, and what our focus this time is on changing lives for a stronger Europe, through health equity. And we're showing that at each stage in every life course, children, young people, working years, later life, you can act to change the trajectory of those people's lives and therefore their well-being and health outcomes. We have modelling investments, which Pete is going to share, showing the benefits for both fiscal and public sector, but also for social and individual resilience and for human capital building. And we will show ultimately how this is critical for trust and social sustainability. So on that basis, I'm going to hand over to Pete. You have to go through them. Yeah, okay, lovely.
There we go. Thank you. It's a pleasure to be back in Trondheim talking about health equity. As Chris mentioned, the first HESRi report was a number of more than 5 years ago, and since then health has not improved for everyone and fragility is increasing. We know this. There are higher risks of illness that limits daily life, higher risks of poor mental health, and higher risks of poor self-reported health. These are all findings from HESRi. This graph illustrates how at each stage of life some of the essential conditions affect health differently. This is of self-reported health, and the red is health care, the green is housing, the yellow is financial insecurity, and the purple is lack of trust and belonging, and the blue is decent work conditions. And we can see that each of them affects life at each stage in life, but a different amount as people go through life. Now, this is not HESRi, this is work we did with welfare for the Norwegian government, but what it shows is that those inequities start early in life. This is upper secondary school and girls, showing the social gradient in expecting to have a good, happy life. And we have similar graphs for boys and similar graphs at lower secondary school. This all comes from Jung data. And this is, I think, one of the messages I'm trying to bring about HESRi is it's a report based on international data that has been submitted by countries, but you can use it to compare countries and then go down to the national level and even lower to the local level. And so it's an input to making detailed studies within each country. Now, I've shown the lack of well-being there. What drives the poor health of young women and men? It's being not in employment, education and training, NEETs, or having unmet need for health care. And this graph and several of them will show the European data and then the comparative data for Norway, showing that although Norway is one of the wealthiest countries in Europe, it still has inequities that mirror some of those in Europe as a whole and the wider WHO European region. Now, just focusing on NEETs for a moment, because as I showed, those inequities start with a social gradient at school. But what we see when people leave school is that many of them, as a result of those inequities earlier in life, don't go into education, employment or training. There is some recent research evidence showing that people who were NEETs between 16 and 24, they have poorer health and poor economic outlooks at that point, but when they're 50, those effects persist. So we see that, as Chris was saying, if we address needs now, we affect people in the coming few years, but also if we fail to do so, we've lost it for a whole generation. And our research in Norway showed that immigrants have higher needs rates than others, but when we looked in Trondheim, we found that it was among those residents who were born in Trondheim and were left behind and stayed in Trondheim that had the highest needs rate. So it shows that these results we're presenting in HESRi, you have to go down to the local context to understand the dynamics of what was happening, which is very much what Uta and Dina said earlier. And investing in health of young people increases participation in employment and reduces social exclusion risks. And this is some of the kind of evidence that we're producing from HESRi. And going back to that issue of mental health, which is poor mental health is growing across Europe and it's costing economies hugely in terms of the productivity of the employed population and those who are failing to be employed, who are needs, etc. And with the demographic shift to an older population, that becomes unsustainable in Europe. And moving on to working years, depression and anxiety disorders have increased. People who are struggling, who have lower incomes, are more likely to be anxious and depressed for a number of reasons which we explore in HESRi. And tackling anxiety and depression then is a key to healthy working years, healthy workers, productive workers. And again, the factors that make people in work anxious and depressed, unmet need for health care, lack of control over the work environment and their lives, and a lack of life satisfaction, of poor well-being. All of these contribute to that and then undermine the economies of countries. Financial decisions that governments make have dire consequences. I think Odd talked a lot about this earlier, so I'll just go over that quickly. And
have to press again. No.
Smart investment in public health policies during working life benefits the economy now and reduces poverty after age 65. So it's important not just for the working population that we do all these things that we've talked about, healthy working conditions, healthy and affordable homes, affordable health services, which all bring benefits during working ages, but also prepare people for retirement. And that, as I said, with a demographic shift to an older population, is really critical. And so if we look at poor health and mental and physical health after retirement, we see, again, unmet need for health care, loneliness and poverty are all factors that undermine a happy and healthy retirement. And again, another graph from Norway showing the effect of volunteering more than 5 hours a week is beneficial in terms of loneliness. So again, this points to some of the solutions to at least one problem, but again, we go through a range of these indicators in HESRi, which are available on the atlas that will become available in September, and which allow people to explore the comparisons between individual countries like Norway and other countries in Europe or neighbouring countries. So staying well in later life is then possible through good public health policies and social support systems. It reduces emergency admissions to hospital and reduces loneliness. And this is the evidence Chris was talking about of what can be achieved through a small tweaking of GDP investment over 4 years, and in a country of 60 million would result in large numbers of lives improved. So social participation and public engagement are key drivers of health, and this is a message all morning, but it comes through in HESRi. It needs involvement with local government, civil society organisations, deliberative democracy, proportional representation, a free press, and gender equity. So a range of factors that are really about the well-being of a society. And that's all from us.
Thank you so much. You know, we could have listened to you the whole day, but we can't. But we're going, and some of us, I just